Hello everyone and welcome back to our another video and welcome to last night dentistry. So as you can see on your screens, today topic is based upon erythroplakia, also known as the dangerous red patch. But before starting our topic, I got something for you guys. That is the clinical scenario. So we will start from a clinical scenario that a 58-year-old male walks into your dental clinic for a routine checkup. During oral examination, you notice something unusual. There is a bright red, velvety patch on the floor of the mouth. Then, what we found is that it is completely painless, present for around 3 months, not scrapable, and the patient is a long term smoker. Now, here is the clinical question. What is the most likely diagnosis? Is it leukoplakia? Is it lichen planus? Or something more serious? Keep this in mind. We will come back to this at the end. Now, we just have seen a clinical scenario. Now, today's topic is erythroplakia, often called the dangerous red patch of the oral cavity. This is not just a lesion, it is a warning sign of potential malignancy. Now, coming at the definition, erythroplakia is a clinical term used for a red patch of oral mucosa that cannot be explained by any other disease. It is important to understand one key point here. This is not a full diagnosis based on microscopic findings. It is purely a clinical description. And behind this red appearance, there is often severe epithelial dysplasia, carcinoma in situ, or even early SCC, also known as squamous cell carcinoma. So, whenever you see erythroplakia, you should not think benign first. Now, coming at the risk factors. Most cases are seen in a very typical patient profile, usually older individuals, strong history of cigarette smoking, sometimes alcohol use as an additional risk factor. Common sites include, also known as the danger zones, are floor of mouth, lateral tongue, ventral tongue, soft palate, and buccal mucosa. These are all high risk areas because of thin epithelium and high exposure to carcinogens. Now, moving forward to the clinical features. Clinically, erythroplakia appears as a bright red, velvety patch or plaque, as you can see here. Early on, the lesion is usually completely asymptomatic, flat or slightly raised, soft in consistency. That is exactly why it is dangerous, because patients ignore it. As it progresses, it may develop burning sensation, pain, or surface ulceration. But by that time, it is often already advanced. Now, moving forward to speckled type of erythroplakia. It is an important variant. Speckled erythroplakia or erythroleukoplakia. Here what you see is a red base mixed with white patches. This combination is extremely significant clinically because this pattern is strongly associated with severe dysplasia, carcinoma in situ, or early invasive carcinoma. So if you see a mixed red or white lesion, you should consider it high risk until proven otherwise. Now, moving at the histopathology. When we look under the microscope, most erythroplakia cases show something serious. What studies show is around 60 to 90% already have dysplasia, carcinoma in situ, or carcinoma. Now, why does it appear rare clinically? There are three main reasons. The logic behind this. First, the keratin layer is lost, so the protective white surface disappears. Second, the epithelium becomes thin, so blood vessels underneath become visible. And the third reason is that the inflammation increases vascularity, making it even redder. So the red color is basically a combination of thinning plus increased blood visibility. Now moving to the carcinoma in situ, it's a very important stage. Carcinoma in situ. Here the entire thickness of the epithelium is abnormal. Cells show severe atypia throughout the epithelium, but there is one critical point. The basement membrane is still intact, so the lesion has not invaded connective tissue yet. The moment this barrier is broken, it becomes invasive squamous cell carcinoma. This is a key exam concept. Now moving at the diagnosis and management. If you see here, clinically you cannot rely on appearance alone. So the gold standard is always biopsy. Small lesion, we will go for an excisional biopsy. Large lesion, we will go for an incisional biopsy. Now treatment depends on histology. If it is dysplasia or carcinoma in situ, then what we will do is remove the lesion surgically, eliminate risk factors like smoking, and follow up regularly. If it is squamous cell carcinoma, so we need a more aggressive surgical management, often combined with radiotherapy, sometimes chemotherapy in advanced cases. Now, coming back to the initial case, what we have discussed is a red velvety lesion on the floor of mouth in a chronic smoker. Persistence for months. The correct diagnosis that we were already discussing in this video is erythroplakia. Because all the red flags are present, first, high risk site, chronic smoker, persistent red lesions, and non-scrapable and asymptomatic. So, final exam points I should discuss with you guys is that erythroplakia is more dangerous than leukoplakia. Most cases already show dysplasia or carcinoma. Biopsy is mandatory in all cases, and speckled erythroplakia is especially high risk. What we also see here is basement membrane integrity separate carcinoma situ from carcinoma. So that's what I have from today. I hope you have enjoyed our video and you have fully built the concept. If you have any queries about this topic, you can just comment, and please subscribe to Last Night Dentistry for more exam preparation. I will definitely make such videos in the future, but I need your guys support. If you keep subscribing, it will be very beneficial for me. Thank you and take care of yourself and your